ADC of CBC. CBC, we all know that whatever condition is there, we do ask for this test. We keep on doing it, we keep on advising it, and then CBC has got a very important role in diagnosis of various hematological as well as the non-hematological disorders. So, in today's presentation, I would try to cover the common problems where the CBC helps us a lot in diagnosing the characterization. So, interpretation of different parameters which are basically reported on the modern day Coulter counters. So now we know that there are the Coulter counters. Earlier we were just getting few parameters like RBC, indices, MCV, MCH, PLC, platelet count, DLC. Only these were available earlier, but now the recent one, the fancy Coulter counters are giving plenty of parameters, and we will be going through one by one that what are those parameters and how to interpret them and how to basically utilize them to reach a proper diagnosis. So these are the various components which are commonly seen in the Coulter counter report, in the CBC report. These are red blood cells, hematocrit, hemoglobin, then MCV, MCH, MCHC, RDW, and WBCs, differentials, and platelet counts. Then RBC counts. So you can look at this slide and you can understand that even in the pediatric age group, at different age, the range of normal RBC counts they vary. So this makes the life of a pediatrician a little bit difficult as compared to physicians, because in adulthood this range remains constant. But as a pediatrician we must understand that like in newborns, the RBC counts are very high, 4.8 to 7.1 million. Then it comes down and around at the age of 1 year it gets stabilized to about 4 to 5 million. Then what is the normal hemoglobin cutoff to basically label a child as in case of anemia? So according to WHO, we all know that 6 months to 5 years it is more than 11 is the normal, 5 to 11 years it is more than 11.5, 12 to 14 years it is 12, above 15 years it is 13 in boys, and in girls above 15 it is 12, and in pregnant women it is 11. MCV is mean corpuscle volume, and the normal value is about 80 to 100 centiliter. If it is small, we'll call it as microcytic. If the MCV is normal, it is normocytic, and if it is more, then it becomes macrocytic. MCHC is mean corpuscular hemoglobin concentration. Normal range is 26 to 34%. When it is reduced, we call it as hypochromic. When it is normal, we call it as normochromic. Then the MCH and the RDW. MCH is basically the range is normal range is 27 to 32 microgram. Then RDW, this is a very important parameter, red cell distribution. This basically, especially for the students, this basically gives you an idea of anisocytosis, the degree of anisocytosis. More the anisocytosis will be there, more the different sizes of cells are there, the more will be the RDW. So, if your Coulter counter is not giving this reading, then please ask for this, and because this is a very important parameter to getting to a particular, you can say, a proper diagnosis. Normal range is 10 to 15%. As I already mentioned, depending upon MCV, we can label it as microcytic, normocytic, or macrocytic anemia. Now the various conditions where you see microcytic anemias, they are iron deficiency anemia, chronic infections, thalassemias, I'm going to say hemoglobinopathies, then sideroblastic anemia, and even the lead poisoning you will find microcytic hypochronic anemia. The normocytic anemia usually seen in chronic anemia of chronic diseases, early iron deficiency anemia, hemoglobinopathies sometimes, Then primary marrow disorders and combined deficiencies. Macrocytic is usually seen in megaloblastic anemia, we all know this. But apart from this, in liver diseases, in alcoholic liver diseases, sometimes in hemoglobinopathies, metabolic disorders, and sometimes in aplastic anemia also, you can find macrocytic disorder. Then the reticulocyte counts. This is also a very important parameter. The reticulocyte count, basically reticulocytes are the younger RBCs. They are the precursors of the RBCs. This important value is very essential for evaluating the anemia. Normal range is about 1 to 2%, and when does this retic count goes up? When there is hemolytic anemia, and due to which the more and more RBCs are being produced. So at that time you will find the retic counts will be on the higher side. But okay, we'll discuss it later. Then retic usually goes down in nutritional deficiency anemias like iron deficiency anemia. So when we are talking about this, in which condition it will increase, we know that in hemolytic anemias it will increase. But one thing is to be remembered that in thalassemia major, you will not find increased reticulocyte. Thalassemia minor, in major, you will not find it. While in other hemolytic anemias, yes, you will find increased reticulocyte. PBF with supravital staining, you will find that. You can see over here. The reticulocyte counts with supravital staining and with Leishman stain. You can see differently here how they look like. Now there is a rule when we look at the CBC. There is a rule of 3, which means when we multiply the RBC count with 3, it will give you hemoglobin level value, and when you multiply the hemoglobin value with 3, it will give you hematocrit. This rule of 3 is very important, because if any patient in any case you find that this rule of 3 is not holding true, then there is some problem. You must look at it. And it can be macrocytosis, it can be microcytosis, it can be hypochromia, whatever. But there will be some problem. So always look at this, whether it holds true or not. Then alone CBC will not basically help you in getting to the right diagnosis. So to get the right diagnosis, you have to look at the smear also. What you look for, like whether the cells are of the same size, whether they are of the normal size, shape and size. What about the color? Whether all RBCs are of the same color or they are multicolored. Are there any RBC inclusions? Are there any intra-RBC hemoparasites? Are leukocytes normal number and differential counts? And what about the platelet, whether they are normal or not, and their distribution and their sizes also. So this is a normal CBC. If you look at the RBC counts, in a normal it is about 5 million, hemoglobin is 16, hematocrit is 47, MCV is 88, MCH is 30, everything is normal, and RDW is 12, within the normal range. And if you multiply RBC count 5 multiplied by 3, it will give 15. So 16 is around 15, so it is normal. Similarly, if you multiply 16 with 3, it will be around 48, 47. So the rule of 3 is holding true for this patient. So this is a normal CBC. Then what will happen in iron deficiency? Iron deficiency anemia, hemoglobin will be low, RBC counts will be on the lower side, MCV, MCH both will be on the lower side, and RDW will be increased. Why RDW will be increased? Because we know that in iron deficiency anemia there is lot of anisocytosis. डिफरेंट साइज के आपको सेल्स देखने को मिलेंगे, इसलिए RDW जो रेड सेल डिस्ट्रीब्यूशन विड्थ है वो बढ़ जाएगा. This is a PBF of a iron deficiency anemia patient. You can see microcytic hypochromic anemia. Then what will happen in megaloblastic anemia? So in megaloblastic anemia, you can see again, hemoglobin is on the lower side, hematocrit low, MCV is high. So mean corpuscle volume is high because the cells are large. So there will be macrocytes on the PBF. And RBC counts is also on the lower side. So when you look at the PBF, in PBF you will find macrocytes and also the hypersegmented neutrophils, where you will find more than 5 lobes in the nucleus of the neutrophils. So this is again you can say a finding which can change the diagnosis for megaloblastic anemia. Then the WBC we all know that there are 2 series, granulocytes, agranulocytes. In granulocytes there will be neutrophil, eosinophil, basophils. Agranulocytes will include lymphocytes, monocytes. We all know the normal ranges and we have to look at whether they are all falling in the normal range or not. Abnormal results क्या हो सकते हैं? So या तो बड़े होंगे या कम होंगे. If it is more, then it is leukocytosis. If it is less, then it is leukopenia. So leukocytosis कहाँ होगा? We all know that in any infective condition, mostly leukocyte counts become high. In inflammatory diseases, there will be leukocytosis. Then leukemia, we all know there will be leukocytosis. And sometimes in severe emotional or physical stress and at the time of tissue damage also, the leukocyte counts will be on the high side. But the leukopenia usually occurs due to the decreased production in the bone marrow. This can happen due to irradiation. This can happen due to exposure to some toxins such as chemicals or drugs. And this can happen also in the bone, in leukemia also. Sometimes in leukemia, we don't have leukocytes, we can find leukopenia also. Then the platelets. So platelets are small, granular, non-nucleated discs. We all know this. And they are basically, what is their function? Dr. Sunil sir has already mentioned it, that they help us in blood clotting. And their lifespan is about 7 to 10 days. So if the platelets are low, we call it as thrombocytopenia, and various causes of thrombocytopenia includes ITP, which is most common in children, then viral infections, bacterial infections, nutritional deficiencies like vitamin B12 deficiency, folic acid deficiency. We usually see thrombocytopenia. In leukemias and lymphomas, this is a very common finding. Then in autoimmune diseases, in hypersplenism, in aplastic anemia, certain drugs can also cause thrombocytopenia, and then alcohol and pregnancy. So now we have a rough idea of that what is CBC, various parameters, what are their normal ranges and how to assess them. So now we will discuss few cases just to understand that how we can apply our knowledge to clinical diagnosis. So we have a 16-year-old female presenting with mild anemia, hemoglobin persistently around 8 grams, no hepatosplenomegaly, no stigmata of iron deficiency anemia or megaloblastic anemia or leukemia on examination. We did a CBC. CBC में आप देखिए, hemoglobin 8.8 low है, RBC on the lower side, although within the normal range but on the lower side. Then hematocrit, no, RBCs are okay. RBC is 4.36. RBC is not on the lower side. RBC is in fact relatively more for this level of hemoglobin. 8.8 hemoglobin पे हम एक्सपेक्ट करते हैं कि उसका RBC काउंट कम होना चाहिए अगर ये आयरन डेफिशिएंसी एनीमिया हो या कोई न्यूट्रिशन डेफिशिएंसी एनीमिया हो. बट यहाँ हम देख रहे हैं कि 8.8 के बावजूद भी उसके RBC काउंट हाई है, 4.36. Then hematocrit is low, MCV is low, MCHC is low, RDW जो है ये इसका normal range है. So what are the various possibilities now? So in any case, when you see this thing that hemoglobin is low but the RBC counts are relatively higher for that degree of anemia, always suspect thalassemia minor. So we did a HPLC. In HPLC, we found that A2, hemoglobin A2 level is 4.6%. So hemoglobin A2 is 4.6%. So any reading above 3.4% is basically indicative of thalassemia minor. So here we can see that the HPLC is 4.6, and this is a case of thalassemia minor. But there is another thing which is called as Menzer index. Menzer index is basically calculated by dividing the MCV by the RBC count. Usually, Menzer index will be less than 13 in thalassemia minor and more than 13 in iron deficiency anemia. But here we found that in this case, the Menzer index is 15. हमने कैलकुलेट किया और ये 15 है, 13 से ज़्यादा है. तो फिर हम इसको कैसे थैलेसीमिया माइनर बोलेंगे? Still it can be thalassemia minor if there is concomitant iron deficiency anemia. So this patient needs further evaluation. इसमें हम serum ferritin करा सकते हैं, iron studies करा सकते हैं, and we will find that if the thalassemia minor, they can have iron. Thalassemia intermediate, thalassemia major cannot have iron deficiency. But thalassemia minor can always, any time, can have iron deficiency. Any time. तो ये कभी नहीं हम सोचना है कि थैलेसीमिया माइनर तो इसको अरे इसमें तो आयरन ओवरलोड हो जाएगा, इसमें आयरन डेफिशिएंसी एनीमिया हो सकता है. एंड इफ वी गिव आयरन टू दिस पेशेंट, वी फीड द पेशेंट, वी गिव आयरन, वी improve, and after 1 or 2 months if we again do the CBC, we will find that the Menzer index will come down. It will come because here what is happening, that the RBC counts are basically due to concomitant iron deficiency anemia, they are getting lower towards the lower side, and that is why our Menzer index value is coming high. So if we will give iron, RBC counts will improve, and then the reading will come down. Case 2.